Today, I am Dr. Alisar Daet. I will be discussing about physical examination and the peripheral vascular system. How do you check the or the problem in the lower extremities or the upper extremities? So for the arms, you check the size. No, this one is this obviously asymmetrical, and there is enlarged left upper extremity, and this is can be secondary to axillary node dissection and radiation therapy. Usually, it is done in patient with a breast CA, so they include the lymph node on the removal. Okay, so skin color. This visible venous collateral discoloration. This is suggestive of upper extremity deep vein thrombosis. Okay, so next is what? The radial pulse and brachial pulse. Okay, so before you proceed to that, the recommended grading of pulses is 3 plus, should be bounding normally, it should be 2 plus brisk or the expected, 1 plus diminished, 0 is absent or unable to palpate. Okay, so if you are unable to palpate, you can put 0. Okay, so brachial artery, radial artery, and ulnar arteries. Okay, so for brachial, so palpate for the brachial pulse. Just let the patient flex the elbow. It is located just medial to the biceps tendon at the antecubital crest and can be palpated at the groove between the biceps and the triceps muscles. For the next is the radial artery. Okay, the radial artery, this is how you palpate using the pulse of your fingers on the flexor surface of the lateral wrist. So sometimes you can partially flex and can help you localize the pulse and compare it to the other hand. This is important for taking the arterial blood gas analysis. And for patients with Raynaud's disease, they say that the wrist pulse are typically normal, but spasm of more distal cause episodes of that demarcated pallor. Okay, so for the ulnar artery, this is done by pressing deeply on the flexor surface of the medial part of the wrist. Now, as you know, that's the other flow, that the other ulnar is on the other side of the radial artery. So there is a dual flow to the hands. So if you want to know the patency of the either ulnar or radial artery, you should perform the Allen's test. So you advise the patient to do this one is for the test of the radial artery. This one is for the ulnar artery. Okay, for the radial artery, you can palms up, tight fist, and then you compress both the radial and ulnar artery. Then you open hand, so it should appear pale, and then after that you release the radial artery. Then there should be a flashing within about 3 to 5 seconds. Now for this other one, this one you can release the ulnar artery and check for the flashing. Okay, usually if there is a palmar flashing, there is Allen test negative. But if there is a pallor, this is Allen test positive. Okay, so it means there is already problem in that area. Okay, ulnar radial. Okay, for the Berger's disease, they have absent or diminished risk, or which can occur in acute embolic occlusion or in Berger's disease. So next is we need to check the epitrochlear lymph nodes, which can be located here or possible presence of cellulitis or possible lymph edema. Okay, next is the abdomen. Uh, Thoracic aorta, iliac artery, supramesenteric, inferior mesenteric artery. These are important branches of the abdominal area. So where can you appreciate the pulsation of abdominal aorta? It's actually in this place. You can appreciate the abdominal aorta at the epigastric areas. You can briefly auscultate in these areas: renal artery, iliac artery, femoral artery. If there is obstruction or murmur here, you consider it a peripheral arterial disease? Yes. Okay, and then you can palpate, estimate the width of the abdominal aorta. So you can measure the aortic width between two fingers. If it is more than 3 centimeter in diameter, it is suggestive of abdominal aortic aneurysm, the triple A. Next is you palpate for the superficial lymph nodes in this abdominal examination. Okay, so abdominal. Next will be the legs. Okay, legs, size, symmetry, and skin color. Okay, SSS. Okay, obviously the size is bigger on the left. This is suggestive of deep vein thrombosis. In the calf area, which is bigger, this one. Say if it is unilateral swelling, measure the calf 10 centimeter below the tibial tuberosity. If it is there asymmetry of more than 3 centimeter, it is increases likelihood of DVT. Okay, or it can be also lymphedema. This is bilateral edema. The other one is unilateral edema or ankle swelling. Or this one is bilateral edema. Most of the time, it can be due to heart failure, cirrhosis, nephrotic syndrome, or if there's a venous distension like this, the edema can be suggestive of venous in origin. Okay, so what is the problem here? What's done, right or left? Okay, you can see there is a cyanosis on the right lower extremity. Okay, so since this is one of the signs of acute ischemia, you see in here, initially the foot can be pale, so it's part of a symptom in patient with acute ischemia. But that's the early part of problem in acute ischemia. But later on can be cyanosis, mottling, and then there's fixed mottling and cyanosis. Sometimes reversible mottling. If there is a local swelling, redness, warmth, and a subcutaneous cord, this signals superficial thrombophlebitis, which is an emerging risk factor for deep vein thrombosis. Okay, so how about the skin color? Okay, you can compare patients with the chronic arterial insufficiency. They can have atrophic changes, means that it can be thin, shiny, atrophic skin with the loss of hair over the foot, toes. The nails are thickened and ridged. So if there is an ulceration, it involves toes or points of trauma on feet. Okay, so usually the color is pale and or dusky red on dependency. For chronic venous insufficiency, they can be brown, or they can be associated stasis dermatitis, thickening of skin, or narrowing of leg as scarring develops. Okay. Chronic venous insufficiency can be brownish, say thickened or brownish skin. It can be due to advanced venous insufficiency. Okay, for arterial insufficiency, no, you can have this necrotic areas. They use it as uh, dry gangrene. Okay, neuropathic ulcers. You have to distinguish it. This is due to diabetic neuropathy. Okay, for the patient with the chronic venous insufficiency, usually it's over the medial and sometimes lateral malleolus. No? It can be a small, painful granulation fissures and presence of fibrine. Okay, so usually the borders are irregularly flat and slightly different. Okay, so that is for the chronic venous insufficiency. Okay, so size, symmetry, skin color. Next is the femoral artery. Okay, so where's the femoral artery? There. Okay, so you can palpate it just below the inguinal ligament, about midway between the anterior superior iliac spine and symphysis pubis, and deep abdominal palpation. You can use the two hands on top of other obese patients. Okay, if the femoral pulse is absent, likely the patient has a peripheral arterial disease. So the occlusion can be where? Can be here, or it can be here, the iliac artery. So they can have a postural color changes. If you change the posture, there will be a change in color. Okay, if there is exaggerated widened femoral pulse, this is suggestive of femoral aneurysm. And the next artery is the popliteal artery. Patient's knee should be somewhat flexed, and it is appreciated at the popliteal fossa, but sometimes it's difficult. You can do this one. You can let the patient lie on prone position and fold the patient's knee to about 90 degrees. Okay. So exaggerated, same with femoral artery aneurysm, you can have a popliteal artery aneurysm. The atherosclerosis most commonly obstruct arteries in the thigh area. This is the thigh area. So femoral pulse is normal, but the popliteal pulse is decreased or absent. So most of the time, there's atherosclerosis on that part. So it's important that you need to examine also the popliteal artery if you highly consider the symptoms of the patient is related to peripheral arterial disease. Next is the dorsalis pedis artery. Okay, so palpate the dorsum of the foot, just lateral to the extensor tendon. This is extensor tendon, rugator, but can be absent. You cannot feel a pulse for the dorsum of the foot more laterally. Okay, next is the posterior tibial pulse of this area, slightly below the medial malleus of the ankle. Okay, so next is already finished with the pulses. Next is you need to check for the presence of edema. It's a pitting edema, no? It can be to heart failure, cirrhosis, malnutrition. No, you can grade it as 1+, 2+, 3+. You can just press on this area. So referentials for pitting. No, usually if it's pitting, and that's appears in it, but non-pitting can be caused by chronic lymphedema or mixed edema, so thyroid problem. And you can grade the edema based on the depth and how long does it last. Okay, so already discussed this one, chronic venous insufficiency, and lymphedema. So for the lymphedema, can initially soft and pitting and becomes indurated, hard and non-so it becomes markedly thickened. For the DBT, the location of edema suggests the point of occlusion. Okay, if it involves only the lower leg or ankle is swollen, I believe it's the iliofemoral veins. If the entire leg is swollen, okay, so if it is on the lower leg, it's only popliteal vein. Ankle is swollen. If the entire leg, you think of the iliofemoral vein. Okay, so this is the femoral vein. This is the great saphenous vein. This is the blood vessel harvested during bypass graft. Okay, so there's a pain. If there's a painful, pale, swollen leg, together with tenderness in groin area, so you can palpate for the femoral vein. This is just medial to the femoral artery. So we think of proximal vein thrombosis, and this one is for the great saphenous vein. If you consider deep vein thrombosis, you can do the hormone signs by making patient legs flex at the knee and relax and palpate for the calf. If there is a tenderness or present support, you consider DBT. Okay, so hopefully at the end you can able to identify extremities are warm and without edema, no varicosities, stasis changes, calves supple and non-tender, all calves are 2 plus and symmetric, that is normal. Extremities are pale below the mid-calf with notable hair loss. This is already suggestive of peripheral arterial disease. Rubor and legs are dependent, no? So highly peripheral arterial disease, but no edema ulceration. Bilateral femoral brewing, it means that the occlusion is on that part. So, but no abdominal brew is heard. So, but you have to check also the iliac artery, because auscultate for the iliac artery, and brachial and radial pulses 2 plus, femoral popliteal, sides pedis, posterior tibial pulses are 1 plus. Okay. Thank you very much for listening.